Good evening, everyone.
Yeah.
I'll be presenting a case of a 38-year-old male farmer hailing from Belgavi, Karnataka, who presented to ophthalmology OPD with complaint of diminution of vision of right eye since 2 years. So the diminution of vision was insidious in onset and gradually progressive. The patient had a history of blunt trauma with to the right eye around 3.5 to 4 years ago. There was severe pain after the trauma, for which he consulted an ophthalmologist. He was told that the eye had blood inside, and he was given treatment for that, but there was no history of sudden decrease or loss of vision following trauma. The past history, personal and family history were not significant, and the general physical examination and systemic examination were within normal limits. Head posture, ocular posture, forehead creases were within normal limits. The uncorrected visual acuity was 660, N6 in right eye, and 66, N6 in left eye. There was no pinhole improvement, and there was a decrease in contrast sensitivity by using Pelly-Robson chart. On retinoscopy, there was a faint glow in right eye while it was plus 1.25, but no subjective correction needed. The extraocular movements were full, free, and painless. The adnexa was within normal limits. The conjunctiva and cornea and the anterior chamber depth and contents were within normal limits. On gonioscopy in right eye, widened ciliary body band was seen, but there was no neovascularization of the angle. The iris, it was normal in color and texture in both eyes, and no NVI was visualized. Pupil, a single central reactive pupil was seen with no abnormality, reactive to direct and indirect reflexes, and no RAPD noted. The lens in right eye showed rosette cataract with an iris shadow. IOP by Goldman applanation done twice on the same day with a 1 hour gap was raised in right eye around 28 millimeters of mercury. This image shows rosette cataract in the right eye. This is the same eye with a history of trauma. Gonioscopic images of the right eye showed widened ciliary body band, widened CBB, suggestive of angle recession in all 4 quadrants, while in the left eye it is within normal limits. On distant direct ophthalmoscopy, a central opacity was visualized in the right eye owing to the rosette cataract. On disc evaluation, horizontal CDR was 0.5:1 and same vertical, and there was a temporal thinning of the neuroretinal rim, and there was nasalization of the vessels. On indirect ophthalmoscopy, the rest of the fundus was within normal limits. This is the fundus diagram of the patient, which I have represented with the increased CDR, and this is the fundus photograph of the patient with increased cup disc ratio in the right eye. Owing to the optic disc changes, HFA was done. A total deviation was total deviation map. Total depression was noted, but this can be owing to the glaucomatous optic disc changes or to the cataract itself, so can't be conclusively said. We made a provisional diagnosis of middle-aged male with raised IOP with traumatic cataract and optic disc changes suggestive of open angle glaucoma secondary to angle recession. Now, patient was started on topical timolol maleate for control to medically control the IOP, and was followed up after 3 weeks, and it was noted that the IOP reduced to 18 mm Hg, and the patient underwent right eye SICS with rigid PCI implantation. The surgery was uneventful. Post-op day vision was 6.9 and IOP was 16.8 by NCT. Post-op 1 week vision was 6/9, IOP was 19.2. Patient has been advised weekly follow-up for IOP monitoring, and OCT, ONH and RNFL and macula will be done to assess for any glaucomatous changes after 6 weeks post-op. Till now, the patient has not come for the 6-week post-op follow-up. So now, angle recession glaucoma is a secondary open angle glaucoma that is associated with ocular trauma. So basically, some people might develop glaucomatous disc changes and vision loss days, months, or even years later. So the mechanism is suddenly after the trauma, the aqueous will push the iris and the iris laterally and posteriorly. This might exert a traction force on the root of the iris, leading to a tear between longitudinal and the ciliary muscles of the ciliary body. This may be the reason of hyphema, as the patient was told. The patient had blood inside the eye. So this may damage the trabecular meshwork and the Schlemm's canal, leading to an early IOP spike. However, long-term scarring and fibrosis of the trabecular meshwork or Schlemm's canal may lead to elevated pressure over the years. Also, loss of tension over the ciliary muscles is another proposed hypothesis of that causes narrowing of the Schlemm's canal. And also, in the long run, a hyaline membrane may form. So now the key examination finding is widening of the ciliary body band, and this differential diagnosis should be made on based on the time since injury. Early rise may be due to trabeculitis, iritis, hyphema, and trabecular disruption, while late may be due to angle recession, peripheral anterior synechiae, ghost cell glaucoma due to the dead RBCs, lens-induced glaucoma, or retained intraocular foreign body. So treatment of angle recession is similar to primary open angle glaucoma. Topical aquosuppressants, including beta blockers, carbonic anhydrase inhibitors, and alpha agonists may be used. Prostaglandin and analogs may be avoided in the acute phase as they have pro-inflammatory effects. And eventually, trabeculectomy with the mitomycin has been shown to be successful in lowering the intraocular pressures. These are my references. Thank you.
Thank you.
So Ishan, I have a few questions from your presentation itself. You had iridodonosis. You have mentioned that there was iridodonosis.
Yes,
what do you expect with the lens? There was a rosette cataract, yes. Can there be something else?
Subluxation might be there.
How does it present as?
Subluxation will have phacodonosis also.
That should have been mentioned. But I really doubt that it was not there. So iridodonosis and phacodonosis have to be seen at different points of examination. One you see without dilatation, one you see with dilatation. Which one is what?
So iridodonosis without dilation, undilated patient, and phacodonosis.
Did you
with
check for
dilatation.
phacodonosis?
Yes, ma'am. We checked for phacodonosis.
Okay. Other thing, in gonioscopy, you have mentioned angle recession. Can there be some other finding? What else can be there in?
Neovascularization of the angle.
No, in trauma, do you?
If in a long-standing,
It's not long-standing, right?
3 to 4 years, ma'am.
Okay. Next.
Other than that, retained intraocular foreign body might be there. Generally, this was
If
a
it's
blunt
a
trauma
penetrating injury, yes.
process. A
Next.
peripheral anterior synechiae might have formed.
Okay.
And highly.
Can there be change in trabecular meshwork pigmentation?
Yes, ma'am.
Yeah, but it's not mentioned in your this thing. If there is a visible hyphema, do you do gonioscopy at that time?
No, ma'am.
How long do you wait?
Ma'am, I will wait for it to resolve first.
And immediately you'll do?
Ma'am?
Immediately will you do gonioscopy after resolution of hyphema? You wait for a week after resolution and then do, because there are chances of secondary bleed.
Okay.
There are a lot of other things, but we don't have time. Anybody else wants to ask?
No, invite the next speaker. I think they are also tired.
Right, thank you.